miscarriage-related incompetence, there is the suggestion that he actually inserted a cyclage where he looked after a pregnancy and then all was well. However, that seems to be fake news. What really happened, according to her own autobiography and according to comments made by Dr. Hubert de Watteville, who was one of the founding fathers of FIGO, the conference of which we enjoyed here in Cape Town so recently, that he came into play having looked after a friend or colleague of Sophia. And he later noted when Sophia and her husband donated a whole U-shaped block of hotels for the use of people who need care in Geneva but may not need to be admitted, said it was necessary for her to make sure that she has a proper balance of hormones, vitamins and mineral elements, and to eliminate all unfavorable bacteriological influences. Very laudable goal, it would seem. You also made a comment that no one should be resigned to not having children without first having made every effort to remedy the causes. In her autobiography, Sophia notes that she actually received a course of several injections of this molecule. And those of you who have recently passed your, well, I wanted to say primary, but even your final, if you have to look at the endocrinology of parturition and pregnancy, that is, of course, estrogen. However, it was probably not pure estrogen, but rather this molecule. This was, after all, the 60s. And if you're sharp-witted, you can figure out what this molecule is that looks a bit like estrogen, but not quite. And you can see these are two ethyl groups. And this is, of course, diethyl stilbestrol. And it was advertised at that time that is very useful in preventing abortion, miscarriage, and premature labor. It's recommended for routine prophylaxis in all pregnancies, and that 90%, that there was a 96% live delivery rate with Desplex in a series of 1,200 patients. And so I think Sophia might be happy that this pregnancy resulted in a birth of a son. And then 4 years later, when she was pregnant again, at that stage, her dressmaker actually injected her the estrogen, probably the DES. And I mean, we all have patients like that they go off and do the injections themselves. Of course, she must have reckoned that the dressmaker is used to working with needles, so she should be okay doing injections as well. But that also resulted in a live birth at term. This time, so Carlo Jr. had a little brother called Eduardo, and she may be happy that those both were boys, that she didn't have a girl with, ended up being a Des daughter. Question is really whether the estrogen would have worked in the first place. And if we look at the effect of estrogen on myometrium, it improves gap junction formation, oxytocin responsiveness, can cause prostaglandin synthesis and release, and would increase uterine contractility. And on the other hand, it also stimulates collagenase and elastase induction, causing cervical ripening and dilatation. So all in all, estrogen is much more likely to cause what it actually sets out to prevent. Whereas the counterpoint of estrogen, namely progesterone, actually causes blockade of calcium mobilization from intracellular deposits, and by means of lots of words that are very difficult to read, actually inhibits uterine contractility. So it might have made more sense had Sophia gone onto a course of progesterone. And we will circle our way back to progesterone again. So this is one of those nice stories that has a happy ending, but at the same time is a cautionary tale because things could have gone much more badly wrong. And who knows if Dr. De Wattel would have ended up as president of FIGO if he landed up Sophia with 2 test daughters. So still staying on the subject of FIGO, this is maybe not so new. This is an article published in last year's International Journal. And of course, then also it wasn't new because it was bandied around in FIGO for a couple of years already. But there are a couple of people whom we saw at the recent SASUOC Congress, also our colleague from the north of the country, putting down what are the FIGO good practice recommendations on optimizing models of care for the prevention and mitigation of preterm birth. And if you look at it, basically the bottom line comes down to looking for pre-pregnancy health. In early pregnancy, sounds as if Kipros had his finger in his pie here as well. There's a risk assessment and care planning. And from there, part of that would be preterm birth assessment, nutrient supplementation and therapy, and then optimizing the care pathways for preterm birth, which basically means getting a midwife to run the patient's care. And if the patient is low risk, she needs reassurance, some more than others, and standard care. And if there's a higher risk, then that patient needs referral to preterm birth prevention services, which sounds very much like something that might be based on a NHS type of model. Then, of course, surveillance is instituted. So if a patient presents with symptoms of preterm labor, she should have a good risk assessment again. And if it then happens that she does go into a labor, the smallest baby or the smallest patient should be transferred in utero after the mom received steroids and, if needed, magnesium sulfate. And of course, it goes on to how should the preterm birth be managed and what should happen after preterm birth, which would mean instituting early breast milk feeding and immediate kangaroo care. However, this leaves me a bit of a loss. Does this change how I practice? Does this change how the private obstetrician should practice? And let's go back a little bit again and borrow something from the Cochrane Review. And this is from 2018, when they had to look at which interventions during pregnancy are effective to prevent preterm birth. The first is this midwife-led continuity models of care, taken up in FIGO. Of interest is zinc supplementation for pregnant women without systemic illnesses. And I keep meaning to, but keep forgetting to have a look at how much zinc is in the common supplements that we dish out for patients. And if someone asks me which supplement to use, my answer is usually go and have a look at what's on special at Clicks. Not that I have anything to declare in a financial incentive from anyone buying anything at Clicks. But now maybe I should tell them, have a look at whatever's on special that has sufficient zinc in it. The third intervention of proven effectivity is antenatal lower genital tract infection screening for women without signs of preterm labor. And that's also something that's not been part and parcel of our routine antenatal care, I don't think. Maybe something for better ops to have a look at. And then where a surgical intervention is needed, only cervical cerclage has been proven to be of benefit, and that's in women with high risk of preterm labor and a singleton pregnancy. So where does this bring us? Now, how do we decide who is at high risk or not? You see, inherent in the Cochrane reviews is we should try and figure out who are at risk. And the same with FIGO, how do we do that? And preterm labor is, of course, a protein syndrome, that has many, many causes, but the final common pathway is that the cervix effaces and shortens. And conversely, measuring the cervical length should be useful because whatever had gone wrong to conspire to cause the woman to go into preterm birth, the cervix should be shortening. And it has been shown that there's an inverse relationship between the cervical length and the gestational age at labor. And it can also be therefore used for the prediction of preterm birth in asymptomatic women, and also used for the management of symptomatic women, the lady that presents in ER or labor ward at 30 weeks with presumed contractions. That brings us to the question of what is a short cervix. And there has been a study from Holland that's been widely criticized because the cervical lengths have been a lot longer than that measured elsewhere. And maybe just because the Dutch are tall people, and it may be that it's measured differently. And they use an absolute cutoff, they use centiles, and in terms of the predictive value, it's also good to remember that it can be used as an absolute risk. In other words, a cervix shorter than 25 millimeters at 20 weeks constitute an X percentage of risk of preterm labor. But it is more useful to incorporate it as a relative risk. In other words, someone that is already at risk, how much extra risk does the short cervix add onto her? And many other issues that aren't quite sorted out is when should we screen, 18 weeks, 20, 22, 24 weeks. And if you really screen too late, it's actually not screening anymore, it's early diagnosis. And should we be looking for funneling? Should we be looking whether it's a T or Y or V or U-shaped cervix, sludge, amniotic separation? That every so often there's something that, a little bubble that floats up in a congress, and in the end, none of those contribute significantly. So far, the one thing that really stood the test of time and practice is the overall length of the cervix. Now, of course, should we now be measuring every patient that's pregnant, or should only the patients at risk of preterm labor with a prior risk doing a transvaginal cervical length measurement, or can we do that transabdominally? Transabdominally is quicker, can be done as part of the routine 20, 18, 22 weeks ultrasound. It is, however, less accurate. The cervix looks longer transabdominally, and all interventions that have been shown to be effective were based on transvaginal screening. And what I've touched on in the previous slide is, should we be screening everybody universally, or should we be doing contingent screening? In other words, moms at risk of preterm labor for whatever reason, should we be screening them, or completely everybody? And this is quite an instructive slide. If we look at all patients with that end up delivering prematurely, those that had at least one previous preterm delivery, those that had two previous preterm deliveries, a cervix less than 15 millimeters, 15 to 30 millimeters. Each of these give you an idea of what the specificity and sensitivity would be. So even if we add all these factors together, there's still a vast amount of preterm delivery that is unexplained and would not be picked up by cervical screening. Now, I like falling back on the ISUOC guidelines, maybe from force of habit. And they brought out guidelines on the role of ultrasound in prediction of spontaneous preterm birth. And they state that where it's possible, transvaginal ultrasound measurement of the cervix should be performed at the second trimester scan for preterm birth. So their guideline is actually doing a transvaginal scan, if feasible, on everybody at the 20-week scan. Now, that is, of course, something to get your head around, because it's a bit of an add-on, but it actually changes the nature of the 20-week scan. And before making such a blanket statement, one should actually know exactly what the false positive and other implications of such a screening protocol would be. Practically, just the way I translate it into practice for myself is that I would have a look at the cervix transabdominally in every patient I see for a 20-week scan. And especially in primigravidae, if I can't see the cervix well enough, that is for me reason enough to ask the patient whether she's okay with scanning transvaginally. Because if I see the cervix well enough and I can measure it, that's fine. But the patients that are slipping through the net are the ones where you think, okay, that is probably okay, and then end up delivering 2 weeks later. And of course, patients with a previous preterm delivery, transvaginal scan is necessary really to triage your care. And how really to measure the cervix accurately. The one option is going the Fetal Medicine Foundation route, which we're all used to in terms of screening for chromosomal abnormalities, screening for preeclampsia. But there is also the Clear Cervical Length Education and Review program, which is a little app or something you can download, and you can log in, load up your pictures, and then they will tell you, are you okay or not. Both of them basically give you quite detailed instructions. In other words, patients should have an empty bladder, which is a good idea anyway, but a big full bladder can make the cervix look longer. And of course, here in this picture, you actually see the patient does have some urine in the bladder, and a little bit doesn't really matter, but with a huge, big, full bladder, obviously going to press on the lower segment and can compress the lower segment, that you can confuse cervix and lower segment, and identify internal os, external os, cervical canal and endocervical mucosa, and the endocervical mucosa is used to define the level of the internal os. And of course, if you press hard on the cervix, you can make the cervix lengthen. The cervix should be magnified, that you're not looking at a little postage stamp somewhere in the corner, but really magnify on the screen what you're looking at. And measure, just take the direct measurement, don't bother tracing around the curvature. And the other important thing is to take 3 measurements over 3 minutes. And I mean, this really stretches your ability to just have small talk going for these 3 minutes. And but usually there's something else of interest lying around. You can pre-measure the uterine arteries. If the baby's lying laid in the pelvis, that's of course brilliant, because you can go and have a look at the baby's brain very nicely as well. But and then in between, make sure that you don't miss this dynamic shortening of the cervix that disappears again once you blink too slowly. And funneling will be noted, but of course that's not really something of extra interest in calculating the risk. Now, so if the mom has a short cervix, what then? And Ramiro really has been one of the proponents of progesterone. And every so often, just I think when he thinks you're going to start lose interest, he published another updated individual patient meta-analysis, and this one made the American Journal of ONG in July of this year. And the effect of vaginal progesterone on preterm birth less than 33 weeks of gestation. And these are asymptomatic patients with a singleton pregnancy, mid-gestation cervix less than 25 millimeters. And you can see it significantly reduces the risk of the early preterm labor and the relative risk 0.63. In other words, it cuts the risk of delivering pretermly with about a third. And the 95% confidence intervals 0.48 to 0.82. In other words, it might be that it reduces as much as 50%, or it might be that it only reduces it as much as 18%. So somewhere between 1 in 5 and 1 in 2 patients will be saved a preterm birth if vaginal progesterone is administered, if the cervix is shorter than 25 millimeters, in likelihood 1 in 3. The multiple pregnancy updated individual patient meta-analysis didn't make the American Journal, but the Ultrasound and Obstetrics and Gynae also this year, which is why we don't have that nice dark black and cobalt blue boxes, but all the kind of shade of gray is the ultrasound that we're looking at every day. But interestingly enough, and that's been the case all along, that for multiples, although progesterone had a bad name at some stage in multiples, if you look at the size and the magnitude of the difference, it's exactly the same. It's a 0.61 relative risk of delivering preterm before 33 weeks. And the confidence intervals are wider because in the end, if you just look at the numbers for the multiples are much smaller. So it's very tempting to say that, maybe the confidence intervals will become narrower, but the size would remain the same. But I mean, practically to be scientifically accurate, we can say it might only reduce the risk of preterm delivery by 2%, but it might in fact reduce it by as much as 62%. So in other words, giving progesterone to an asymptomatic mom with twin to the cervix less than 25 millimeters at 20 weeks, you might need to give it to 50 moms to prevent 1 preterm labor, but it might actually, if you give it to 3 moms, it might actually prevent preterm birth in 2 of them. And practically, it's likely to cut the risk by 1 in 3. And how should we be giving the progesterone? Basically, vaginally administered progesterone. And what we can say, if we take all the statistics together, there's a high certainty of reducing preterm birth below 34 weeks. And this is taking all at-risk women. This is not just those with a short cervix. And there's a moderate certainty for the prevention of perinatal death. And recommendation is 200 milligram micronized progesterone every night vaginally. And giving it twice a day, giving 800 milligrams a day, there might be scenarios in terms of infertility treatment where it might make sense. I don't know, that's beyond me. But for prevention of preterm birth, this is what's needed. Not oral, not 400 milligrams twice a day, 200 milligrams at night. And this is really for these asymptomatic women with a cervix less than 25 millimeters detected before 24 weeks. And you give it from the time of detecting the short cervix until 36 weeks. Other things, bed rest, stopping exercise doesn't make a difference. Cerclage makes a difference if the cervix drops to less than 10 millimeters. So if the cervix is less than 25 millimeters, start the progesterone, measure the cervix regularly. If it drops to below 10 millimeters, below 24 weeks, put in a cerclage. What if it's 25 or 26 weeks? Who knows? I don't know. The Arabin pessary every so often, gets mentioned, but there's no good evidence to use that outside research protocols. How should we factor in other risk factors? And in some of the previous preterm delivery, basically previous preterm delivery before 36 weeks just gives progesterone to everybody. And of course, there is a subgroup in there with a normal cervix, and that might have less effect. And in a subgroup with a shorter cervix, there's probably a stronger effect or a smaller number needed to treat. And if the cervix shortens on progesterone early enough in pregnancy, that's definitely someone where a cyclage would be considered. And how, again, previous preterm delivery and cervical incompetence, and how is that diagnosed? Of course, it is suggested by someone presenting relatively pain-free in an advanced stage of cervical dilatation, or someone with the early second trimester pregnancy loss. And there we can consider a history-indicated cyclage placement at 12 to 14 weeks. And we know that there's a good proven decrease in preterm birth below 37 weeks. And, you know, I'm not going to go too much into the cyclage because that's a talk on its own. We can take the new kid on the block, the McDonald's, that actually described the cyclage after Sharatkar, where they use mono and polyfilament. And somewhere I heard the story that Sharatkar originally did his cyclage with stainless steel wire. And, you know, that also seems like a myth that's busted because he initially used 3 strands of catgut, chromic catgut, but found that didn't work so well. So he actually took a strip of fascia lata and used that, and then later on the synthetic materials have been used. All right. And in someone, we've been talking about the asymptomatic patient with no history of preterm labor, the short cervix. If someone has had a previous preterm labor and the cervix is short, then progesterone and cyclage has a similar effect. And, you know, I think then you can pretty much make a case either way. Some of the previous leads basically can be monitored as anyone else, although there is some evidence that the patient with leads can experience shortening of the cervix happening at a more rapid rate than those without the previous leads. And there might be other risk factors like multifibroid uterus, congenital uterine anomalies, connective tissue disease, and that's basically the same kind of story. So in summary, in the asymptomatic patient, ideally do a single measurement of cervical length using transvaginal ultrasound between 18 and 24 weeks. And we talked about abdominal versus vaginal ultrasound. Cervix longer than 25 millimeters, nothing necessary. Short 2 progesterone daily, 200 milligrams micronized progesterone until 36 weeks. Follow her up every week or 2. The cervix drops below 10 millimeters before 24 weeks. Consider the cyclage. And in the symptomatic patient, or the patient with a previous spontaneous singleton delivery in the lateral for the second trimester, 14 to 27 weeks, start off measuring at 14 weeks. The one later you can start off measuring at 16 weeks. And then long cervix, just repeat it every 2 weeks. And in between 26 to 29 millimeters, measure weekly. Less than 25 millimeters, consider cyclage and maintain the progesterone. Of course, there are multifactorial models, not depending just on the cervix. The FMF, probably the most advanced of those. It does work out the risk in the first trimester, but this is one of the predictive models in the first trimester that doesn't work well. If we use it, we should be using at mid-gestation And of course, there are other different models as well. In symptomatic preterm labor, basically depending a lot on the cervical length measurements, things like fetal fibronectin can be a big help, but their progesterone is nothing more than a semi-logical placebo. And good to remember that every medication is poison in the correct dosage. And remember our cautionary tale. And of course, micronized progesterone is really unlikely to be involved even on long-term follow-up with many of the serious detrimental effects. But I think it's also, at the same time, there is always the things like bracket creep and indication creep. We know it's excellent at preventing preterm labor, but once preterm labor has started, it doesn't really have much sense. And in other words, for asymptomatic prevention in a patient with a short cervix, whether or not there's a previous preterm delivery or not, it's an effective means measuring the cervix and give you progesterone. In symptomatic preterm labor is a kind of illogical placebo. And hopefully, with these measurements, we can keep death away from the moms and babies that we are looking at. Thank you, and I'm happy.
Well, thank you very much indeed, Professor Lou Pistorius. And Chris, do we have Lou with us at the moment, or is he still with his
Yes,
oh, yeah,
yes,
you are.
Yes, I'm there. And I'm really have sympathy with you. I put myself to sleep towards the end there. So
it's wonderful, wonderful having you back.
No,
Lou,
thanks,
thank
Peter.
you so
Thanks,
much.
Stephen.
And Steve, Steve, are you there as well?
Well, I'm here. Hi, Pete. Yes, thanks very much. Hi.
Hi, Stephen.
Can we run through the questions, Steve? Just let's have a look. See, can you just see if there are any questions, Steve?
I don't actually see any questions on the chat. Let me just see if there's anything else here that I can see.
Okay, I've got one or two that have come through on the SMS. Didn't you have any on the chats? Can I ask Lou with the other questions that I've got over here come through on my WhatsApp? Would I do that?
Absolutely, go ahead, Pete.
Lou, the question is this, this preterm birth, one or two questions over here, just to take a representative sample. What tocolytics are practically available to people that have symptomatic preterm labor before 32 weeks? What would you say is a practical answer to that question? Which tocolytics are you familiar with that think that do have evidence to say they work?
Right, yes. So, I mean, that's of course a completely different topic. And the one tocolytic, which is unfortunately expensive and not generally available, would be atosibin, the oxytocin antagonist. And so other than the expense, it works well and has very few maternal and fetal side effects. If you can't use that, then you're actually a little bit stuffed in that all the different drugs have their own side effects and pros and cons. Probably the one that's been used the most in our own institution would be nifedipine.
Yep. How good is it?
Studies have proven that it's good as a tocolytic. The one thing we tend to see, again, it's the same story of the bracket creep or indication creep, is that often the patient goes home and she's on nifedipine for the rest of her pregnancy, which doesn't really make sense in that you really want a tocolytic for the 48 hours to get the celestine on board. And after that, there's not really any good evidence that you're doing anything.
Yeah.
Other than that, the beta-2 stimulants have fallen a bit out of favor because of the risk of maternal pulmonary edema. And, coming from the fetal side, I know I shouldn't say, but the Non-steroidals like indomethacin actually works very well if used before 32 weeks, just given for that 48 hours to get the steroids on board and not give it too late where there's a bigger risk of closing the duct.
Okay.
And
And
so
is there any point at all in using micronized progesterone? I think that was the thrust of their question.
Yeah, that's right. Yes. So there's actually not that much point in giving the micronized progesterone in someone that's presented with symptomatic preterm labor. And I know many people will shoot me down for this, but again, in the acute phase, it's not going to do much. And on the longer term, there's not really any good evidence to say that it reduces the risk of even readmission or reduces the risk of, in the end, preterm delivery, let alone reducing the risk of perinatal mortality.
Thanks, Lou. The question is, in the public sector, the anonymous attendee says, we're running short of adalat, nifedipine, and salbutamol. What other options? Now, you've answered that question. Perhaps if it's before 32 weeks, you can use non-steroidal for a very short period, just while your celestone is being used. But nothing else really seems to be doing, because I don't think in the public sector they do have tracloseal available, to my knowledge. And then uterogestane, you've just answered that. Yeah. Thank you very much indeed.
Pete, just from our side, what do you actually use? I mean, your practice, I mean, you've got a very busy obstetric practice. How do you approach your preterm labors?
Yeah, there's one or two other things that we could, some people like to use, whether it works or not, is some form of antibiotic, on the assumption that preterm labor may be associated with chorion amnionitis, be it clinical or subclinical. So I'm not sure if that does harm or not. Would you use it then, Lou? What is your feeling? Antibiotics?
Yeah, so in generally with ruptured membranes, and there's some question about exposed membranes. In a patient with still cervix that's closed, you know, there is the question whether that really adds much. And of course, we know that preterm labor is so strongly associated with chorioamnionitis and amniotic and intrauterine infection syndrome. I think it's one of those things that makes sense, but the evidence really lies more in the group where there's ruptured or exposed membranes.
Okay. Sorry?
So, and then of course, you know, the group B streptococci, of course, a different kettle of fish, because there you want to treat that specific bug.
Yeah. You know, when I started obstetrics, the Americans used to use intravenous alcohol. That's probably before your time, Lou. And the other thing they used to use is magnesium sulfate. Let's leave alcohol out of the mix. How good or bad is magnesium sulfate? Because it certainly is available and certainly is cheap. I don't think everyone will ever run out of the stuff.
Yeah, that's right. And I think we are probably a little bit unnecessarily worried about the magnesium sulfate. And where I really had a good first-hand involvement with that was the first couple of patients that received intrauterine surgery for spina bifida repair. So we had a group from the MOM study from the States coming out to Leuven. And so I think for the first 10 or 20 cases, they used the exact same protocol, exact same criteria, exact same surgical techniques. And there they also used magnesium sulfate as a tocolytic. And I realized that we are really woozies. You know, we were worried about magnesium sulfate. And there, if the patient could still open her eyes easily and talk coherently, you know, then the magnesium levels weren't high enough. So it was really given to a very much higher level than we used to using it for preeclampsia or for imminent eclampsia. And of course, the patient's morbidity profile is going to be a little bit different. But I mean, as you say, it works. It's cheap. It's generally available. And I think the only caution I would have there is that, you don't want a little junior nursey just opening up the drip and the patient ends up in respiratory arrest.
Yeah. Okay, thanks for that then, Lou. We have got Pitt Roos here. Welcome, Pitt. He says, what about zinc in prevention of amniotic fluid infection? Do you have any experience with that, Lou?
No, so I think zinc's probably, as I mentioned, one of the bubbling under minerals or supplements, in that, I mean, there are so few things that actually to make it with a Cochrane in terms of effective prevention of preterm labor and of course then inherently the intrauterine infection syndrome. So all I can say is that Cochrane says it works, and I think practically how to apply that in your day-to-day practice, I don't really have a good take on that.
Okay, is that given orally or intravenously? How does it work? Is it
so the what I'm thinking of would be that is given as a supplement, so part of the
okay.
Preg Omega 2000 triple plus or whatever patients use, so it as long as it's in there, the patients probably get enough zinc.
Okay, because I was going through my drawers the other day and I found huge amounts of zinc from my COVID days. You won't remember, but 5 years ago, we were all buying as much zinc as we possibly could for the prevention of COVID. And I have no idea what to do with it, but certainly it sounds like I can use it now in preterm labor. There's a thing.
That's right.
Steve, if you don't have any more, can I carry on with some other questions? Lou, shall we just leave aside the questions on cervical sutures, because we were really talking about micronized progesterone. So can I just ask one last question and then we can leave cervical sutures alone. Is there any optimal way of doing it? I'd like you just to comment on, should you do it vaginally or should you do it abdominally with laparoscopy? And if so, what material should you use? Then we can leave it alone, put it to bed.
Good, And back when I was a registrar, if you wanted to get a whole group fighting, you should talk about circulars, and I think it's not much different.
No.
And so for me, it's still the abdominal circulars. It's really the place where suitably inserted vaginal circulars has failed. And of course, we are human, and there are patients where you'd think, the history was really so horrendous that you would use that in the first instance. The criteria would still be to not use it as the first circular the patient has. And in terms of whether it's done as an elective circular or as an emergency procedure, shouldn't really make a difference. And I've got used to doing the Sirotco just, and, the reason I like it is just that I don't do that many, that I can keep my hand in it if I just use it for the emergency and membranes exposed and bulging type of circulages. Why I like it.
Is that when you do it for vaginally, when you go and poke the membranes back and put a few stitches in to encourage the cervix to make itself some length?
That's right, yes. And what's nice to me of the Sirotco is you don't go through the cervix. So also really putting your needle through the membranes is low.
Yeah.
On the other hand, if someone really has this short, slightly dilated membranes presenter kind of cervix, then I would put in borrow a catheter from the urologist with a big 20 or 30 milliliter balloon, put that in the cervical canal, blow it up, and then the membranes shift up and out of the way. And if you do that, and then if you put the McDonald through, if you are going to put it through something, it will be through the catheter, not through the membrane. So I suppose that argument of mine doesn't make all that much sense. And I know there has been a move towards using monofilaments rather than our saline type of sutures. And there is definitely some evidence that actually might work better, but it's again like many of the things here at the Congress, is a couple of small case series that seems to work well, and then it never. I haven't seen it making it beyond that.
Yeah. Things do change. I spent the morning with Suleiman Halen, who does, he's a master laparoscopist, and he does a laparoscopic abdominal cerclage in 45 minutes. Look, we can't do that. He's being the magician, he can do it. And they do seem to work. Unfortunately, the only problem is that if you get a fetal abnormality or a cardiac baby or something, it does, or even a miscarriage, it does cause problems. But you can do an evacuation through a cervix that has been cerclaged. Yeah, and Steve, any other questions? Because we must now let Professor Pistorius go. Anything else, Steve, before we say goodbye? Hello, Steve.
I have actually, I have actually seen you doing a number of the laparoscopic, cerclages with Suleiman, and I mean, I think your indications are quite narrow for that, Pete, but I mean, it does seem to be a fairly nice operation, actually, if it's done in, but Suleiman certainly makes it look very easy. So, but I think obviously, you've got discretion in terms of how you choose that. But yeah, I mean, I don't have any other questions.
Okay, would you mind thanking Lou Pistorius in that case?
Absolutely, yeah. Thank you very much, Lou. It's been wonderful to just really get, just your opinion and your great scientific insights into the role, especially of the progesterones. I mean, I think we're talking more and more about it, and it certainly seems to be an area that has evolved very nicely over the last few years. So, I mean, really just getting some evidence on that seems to really have made it a huge difference to the way we practice. So thanks so much for giving that to us. And again, thanks so much for taking time. It sounds like you've had quite a hectic day there as well. So thanks for making it to give the talk and making yourself even available for the questions. So we really do appreciate that.
And can I just have the final word there, Steve?
Yes, of course.
Yeah, those of us that went to FIGO, it's a very expensive exercise, and there are drawbacks, but we did have some beautiful talks. And Lou mentioned in this case that you start preterm birth assessment on day 1 of pregnancy. And that is also true perhaps of another very, very thorny issue. And Lou he's published in the South African Medical Journal on that with Ishmael and Priya, and who was the third person? Buchmann, about cerebral palsy. Lou, do you know what I'm referring to? The SAMJ paper on cerebral palsy starts, in fact, not during labor, but in fact during pregnancy. Do you know to which I'm referring? Are you still there, Lou?
Yes, I'm with you. Yes.
Yeah. So I think that our new perspectives of these conditions are evolving, and particularly CP as well. It doesn't start when the woman goes into labor. It starts, in fact, when she falls pregnant, with those precedents that can happen during the antenatal course. So we must actually expand our thoughts and take these into consideration.
Yeah, I can only agree. And sometimes you might even argue it starts even before she falls pregnant. That there are different genetic predispositions to that as well. So as you say, it's not as easy as blame the obstetrician.
Yeah, it's always been a bit of a shooting match for us, the guys that do labor normal deliveries. We now know from that paper that you presented, Lou, that only 14% of babies that develop cerebral palsy have it as HIE during the actual labor. So it's something we have to relook at and do the genetics and those other predisposing tripping up factors. But we've now got to 6 o'clock, Lou. I'd like to thank firstly Medi Challenge and Danitza, who's still with us. Thank you very much indeed. Do we have any more videos from Medi Challenge, Chris, or have we done that sufficiently?
We've done that sufficiently.
Thanks so much. And a special thank you to Chris for his... Yeah.
So, can I just add something that we are planning as a foundation? So following on the talk from last week about hysterectomy, we are planning a Meet the Experts breakfast type session for those of you who want to spend about 3 or 4 hours on the 15th. No, sorry. What date is it again, Chris? It's the week later. It's on the 15th, actually, of November. At this late premises, we will be sending out a marketing thing about that. So anyone who wants to spend a bit of time with me and two other experts, Gary Groenewald and Jan-Paul Rufus, learning about how to embark on starting your own journey in doing laparoscopic hysterectomy or robotic if you want to. You can come and spend the morning with us over there. And then we are planning something on pelvic pain, recurrent bladder infections, and interstitial cystitis 2 weeks later.
Who's doing that, Steve?
Well, we are looking at bringing in some experts, but we're still putting that one together, Pete. So we'll definitely be letting everyone know about that. But that'll be marketed for urologists as well. But a very thorny subject for us, people who treat patients with bladder infections, and we're trying to understand how to embark on approaching recurrent urinary tract infections. And then one other thing, Chris, we'll be sending out a few things about plans for other live sessions and live workshops for those of you who want to join us.
It's going to be fun.
Yeah.
Also,
Thanks,
in terms of in terms of our diaries, we've got SASOG next year, and also SAUGA, South African Urogynecological Association, meetings next year. So there's lots of academia coming up. And just because we've had FIGO, which was absolutely wonderful. And incidentally, just before I know we have run out of time, I'd like to thank people like Lou Pistorius and you, Steve, and people like Ronnie Thacker and Abdul Sultan, who put so much into the workshops. And we had over 800 South African obstetricians, gynecologists come. So a big shout out to all the delegates who spent all that money, came down to Cape Town, and were part of the delegate body. We had a wonderful time, very good delegate experience. And I'm not sure if they can repeat that in Montreal, but that's another question. So on behalf of us, Steve, thank you very much indeed. You have the last word, Steve.
Oh, well, and then, of course, thanks to Pete. I mean, we know that the whole FIGO initiative, getting the whole conference to Cape Town, was almost single-handedly initiated by Pete. I remember Pete was having huge meetings with the FIGO delegates and the FIGO body board, trying to persuade them to bring it to Cape Town. And indeed, it was great for us, great for the city, and just really a wonderful meeting to be at for those of us who could be there. So thanks so much, Pete.
A great pleasure.
Thank you.
Until next week. Good luck.
So much.
Thanks so much. Same time, same place, ladies and gentlemen. Thanks to our sponsors and to Chris for putting it all together. A big shout out to Lou Pistorius and his panorama situations. It's been wonderful having you, Lou. Steve, thank you very much indeed. To all of us, good night, good luck, and see you all next week, same time, same place.
Thank you very much, Pete.
Thanks a lot. Bye-bye.
Bye, Lou.